5 medical checkups I'd never get after 65. Doctor explains. The landscape of healthcare, particularly as we age, is far more intricate than often presented. Consider a scenario that, regrettably, is anything but uncommon in medical practice. A vibrant man of 71 years, having gracefully entered retirement, maintains a remarkable sharpness of mind and body. He still meticulously mows his own expansive lawn, a testament to his enduring physical vigor, and faithfully drives himself to his cherished Tuesday poker games, symbols of his cherished independence and social engagement. His devoted wife, driven by a natural concern for his well-being, finally succeeds in persuading him to undergo a physical examination he had diligently avoided for 2 years. The doctor, after a thorough initial assessment, confidently declares, "Everything seems fine." These reassuring words are quickly followed by a short, seemingly innocuous phrase. 6 words that, in retrospect, would utterly reconfigure the trajectory of his life. Let's just run a few tests. Merely 3 months following that seemingly routine appointment, this very same man finds himself in a protracted recovery from a medical procedure that, in truth, he never genuinely required. He is grappling with the aftermath of a condition that, left undisturbed, would almost certainly never have posed a threat to his health or quality of life. Adding to his distress, he is simultaneously contending with a series of debilitating complications that bear no direct relation to the initial reason he walked into the clinic that day. The vibrant, independent life he knew before that fateful appointment, the satisfying rhythm of his lawn care, the camaraderie of his poker nights, the very essence of his autonomy, that cherished version of his existence has irrevocably vanished. This deeply troubling narrative, far from being an isolated incident, repeats itself with disheartening frequency within our healthcare system. It is a phenomenon so prevalent and distinct that it has earned its own definitive classification within established medical literature. And it is precisely this critical issue that we are poised to discuss with unwavering honesty and transparency today. My name is Dr. Thomas, and I am a dedicated physician whose expertise lies in the intricate fields of cardiovascular health and the physiological changes associated with aging. My specific focus within this broad domain centers on understanding precisely how the body's complex circulatory system evolves and adapts after the age of 60, and, more importantly, what these age-related changes fundamentally signify for the way we approach and make medical decisions in older adulthood. Throughout my extensive work with adults beyond their 6th decade, a consistent and deeply concerning pattern has emerged repeatedly. I encounter individuals who, prior to a seemingly innocuous routine medical appointment, felt unequivocally healthy and robust. Yet, they emerge from that very same appointment facing an entirely new medical challenge, dealing with conditions or complications that were utterly absent before the commencement of the initial diagnostic tests. This pervasive pattern, this recurring chain of events, is not random. It is driven by a discernible mechanism, and it possesses a specific, recognized name. My conviction is that once you grasp the full implications of this phenomenon, your perspective on medical appointments will be profoundly and permanently altered. To underscore the gravity of this issue, consider a sobering statistic that should compel every individual to pause and reflect. Comprehensive studies and analyses estimate that a staggering proportion, between 15 and 25%, of all medical procedures performed across the United States annually are, by medical standards, entirely unnecessary. This is a monumental figure, representing millions of interventions that may not only fail to provide benefit, but can actively introduce harm. However, there is an even more alarming facet to this statistic, one that, for various reasons, is rarely openly discussed in clinical settings. This already substantial percentage of unnecessary procedures escalates dramatically once a patient surpasses the age of 65. It is crucial to understand that this sharp increase is not attributable to older patients inherently being sicker or more frail. Rather, it is because the fundamental risk-to-benefit calculus, the careful weighing of potential advantages against potential harms, undergoes a complete and radical shift after the age of 65. The inherent design of our modern medical system, often characterized by brief 15-minute appointment slots, is simply not structured or equipped to adequately perform this nuanced, age-adjusted mathematical assessment in a way that truly serves the best interests of the older patient. This brings us to a crucial concept known as the cascade effect. Its mechanism is as insidious as it is straightforward. It begins innocuously. A single routine medical test uncovers a minor abnormality, perhaps a deviation from a statistical norm that holds little clinical significance for an older individual. This detected abnormality, however small, then invariably triggers a recommendation for a subsequent, more invasive follow-up scan. The findings of this scan, in turn, often prompt the ordering of a biopsy designed to provide a more definitive diagnosis. The biopsy, depending on its results, frequently culminates in a recommendation for a medical procedure, such as surgery or a targeted intervention. This procedure, despite being undertaken with the best intentions, unfortunately carries its own inherent risks and, in a significant number of cases, leads directly to a complication. Thus, a person who initially entered the medical system feeling perfectly healthy and symptom-free now finds themselves managing a complex medical situation, a predicament that was entirely absent from their life before they simply said yes to that initial, seemingly benign test. It is vital to emphasize that the cascade does not commence with the major surgery or the significant intervention. Its genesis is in that very first, seemingly minor diagnostic test. This profound insight forms the very bedrock of our discussion today. My aim is to meticulously guide you through 5 specific medical checkups, tests that, from my professional perspective and informed by extensive data, I would personally and strongly advise individuals over the age of 65 to reconsider before automatically consenting. This recommendation is not rooted in a belief that modern medicine is inherently flawed or broken. Rather, it stems from the undeniable reality that after the age of 65, the inherent risk-to-benefit equation dramatically shifts, often in ways that are not immediately apparent. Critically, very few doctors, constrained by time and systemic pressures, engage in this essential calculation transparently and verbally with their patients. I will elucidate precisely why this mathematical shift occurs, sharing compelling examples of real-world patient experiences and outcomes I have personally witnessed. Furthermore, at the conclusion of this comprehensive discussion, I will equip you with a concise yet powerful set of specific questions. These questions, when employed during your next medical appointment, will fundamentally transform the nature of the conversation you have with your physician, empowering you to become a more informed and proactive participant in your own healthcare. I urge you to remain with me through the detailed explanation of all 5 checkups, as each holds critical insights. Be especially attentive to checkup number 3, which often profoundly surprises people because it involves a test that, on the surface, appears to be an embodiment of pure common sense and responsible health management. Finally, checkup number 1, the culmination of our list, addresses a medical assessment that almost no one dares to question, despite the fact that the underlying data supporting its routine application in older adults is arguably more troubling and carries more potential for adverse outcomes than nearly any other item on this entire list. Before we delve into the specifics, I invite you to share your city or state in the comments section below. I genuinely make an effort to read every single one of these comments, as it provides invaluable insight into the diverse community that has coalesced around this channel. And understanding who is watching truly means a great deal to me. But first, let us establish one foundational concept, for without its complete understanding, the subsequent information I present today may not fully resonate or land with its intended impact. I refer to this vital concept as the longevity lens. Here is how it functions, illustrating the dramatic shift in perspective required. When you are a healthy individual at the age of 50, engaging in routine medical screening is, without question, one of the most prudent and effective investments you can possibly make in your long-term health. At this stage of life, the objective is clear and the math is elegantly straightforward. If a potential problem is detected early through screening, intervention can often be swift and effective. Treating an emerging condition at its nascent stage offers the genuine prospect of mitigating its progression, potentially buying you an additional 30 or more years of robust, high-quality life. In this context, the mathematical equation is clean, unambiguous, and profoundly rewarding. The investment in screening clearly pays substantial dividends. However, once you cross the threshold of 65, three critical factors emerge that fundamentally alter this previously clear and beneficial mathematical equation. The entire calculus undergoes a profound transformation. Firstly, a significant proportion of the medical conditions that routine screening tests are designed to identify in adults over the age of 65 will, in actual fact, never progress to cause you any discernible harm or symptoms. Many of these age-related findings, often subtle and minor, are characterized by an exceedingly slow rate of growth or progression. They frequently remain entirely asymptomatic, never manifesting in a way that impacts your daily life or well-being. In a considerable number of documented cases, an individual will simply outlive the potential clinical significance of these slow-developing conditions. The challenge arises because once an abnormal or even marginally elevated result appears on a medical report, the current medical paradigm, driven by a bias towards action and a fear of litigation, lacks a readily available or commonly utilized leave it alone button. Instead, the system is hardwired with a treatment button, and once a finding is identified, that button almost inevitably gets pressed, initiating a chain of events that may be entirely unwarranted. Secondly, and equally critically, your body's inherent resilience and tolerance for medical intervention are simply not what they were at the age of 50. The physiological capacity for recovery diminishes with advancing age. A surgical procedure from which a healthy 58-year-old might comfortably bounce back within a mere 2 weeks, returning to their normal activities with relative ease, can translate into an arduous and protracted recovery spanning many months for a 73-year-old. This extended recovery often comes accompanied by a heightened risk of complications, a significant and often permanent loss of independence, and a profound degradation in overall quality of life that looks starkly different from their pre-procedure state. The body's reserve capacity for healing and adaptation simply isn't the same. Thirdly, we confront the omnipresent danger of the cascade effect once more. This intricate chain reaction is initiated by a single, seemingly minor test, which uncovers one slight abnormality, setting in motion a series of increasingly invasive events that, remember, originated from a starting point where the individual felt entirely well and symptom-free. It is imperative to keep this longevity lens, this adjusted perspective on risks and benefits in older age, firmly in mind as we meticulously examine each subsequent item on our list. All right, let's delve into the specific checkups, beginning with number 5. Checkup number 5, routine PSA prostate testing after 70 in low-risk asymptomatic men. This particular recommendation demands a high degree of precision and careful nuance, as it is regrettably prone to misinterpretation. To be unequivocally clear, I am not suggesting that prostate cancer is an unreal or insignificant disease. Nor am I asserting that PSA, prostate-specific antigen testing possesses no clinical value whatsoever. My specific contention, supported by a substantial body of evidence, is that for men who have surpassed the age of 70, exhibit no concerning urinary symptoms, have no family history of prostate cancer, and have no prior medical concerns regarding their prostate health, the data regarding routine PSA testing narrates a story that, regrettably, most men sitting in their doctor's office have never been fully apprised of. The core issue here is deeply biological and profoundly impactful. A PSA test is highly sensitive and capable of detecting a prostate cancer that, biologically speaking, is barely progressing. We are often talking about a slow-growing, indolent tumor, a malignancy so sluggish in its development that, if simply left undisturbed and monitored, it would never disseminate beyond the prostate, never produce a single noticeable symptom, and, most crucially, in a healthy 71-year-old man, it would almost certainly never shorten his natural lifespan. He would, in essence, live with this type of cancer, rather than ever truly suffering or dying from it. However, the precise moment that PSA test result returns as elevated, even slightly, the medical system is primed for immediate action. It rarely waits and watches. Biopsies are promptly ordered. Referrals to specialists, typically urologists and oncologists, are made with urgency, and a range of aggressive treatment options, including surgical removal, radiation therapy, hormone manipulation, are presented as standard protocol. For a man who is 71 and otherwise robustly healthy, intervention for such a low-grade prostate cancer carries substantial and often life-altering risks. These treatments can profoundly impact urinary continence, sexual function, energy levels, and fundamentally his overall quality of life. It is precisely because of this pervasive problem of overdiagnosis and overtreatment of indolent cancers that the American Cancer Society has specifically updated its guidance regarding PSA screening. Their recommendations now clearly state that for men with a life expectancy of less than 10 years, or for older men at average risk who present without any symptoms, the potential risks associated with finding and subsequently treating a slow-moving, clinically insignificant cancer frequently and demonstrably outweigh any potential benefits. Let me illustrate this with the compelling case of Raymond. Raymond, a 74-year-old retired electrician hailing from Tulsa, Oklahoma, was by all accounts a picture of health. He was fit, remained actively engaged in his community, reported no family history of prostate cancer, and exhibited absolutely no urinary symptoms whatsoever. During his annual physical examination, a routine PSA test was performed, returning a result that was deemed slightly elevated. This finding immediately triggered a recommendation for a biopsy, which subsequently confirmed a low-grade, slow-growing prostate cancer, assigned a Gleason score of 6. In precise medical terminology, a Gleason score of 6 represents the least aggressive form of prostate cancer, indicating that it is about as slow-moving and least threatening as prostate cancer typically gets. His urologist, adhering to standard protocols, recommended a course of radiation therapy. Raymond, placing his full trust in the professional recommendation, proceeded with the prescribed treatment. Within an alarming 8 months post-treatment, Raymond found himself struggling with chronic fatigue so profound that it utterly grounded his mornings, making it difficult to embark on his usual active routine. He developed a relentless urinary urgency that profoundly altered how he was able to live his days, severely limiting his previous freedoms. His overall quality of life had plummeted in ways he had simply never anticipated or been warned about. When he sat down with me for a consultation a year after undergoing treatment, the words he used were both poignant and deeply resonant. "I felt better before they found it than I do now that they fixed it." This exact sentiment is not merely anecdotal. It appears with disheartening consistency throughout the medical literature, a recurring theme that should compel every man over the age of 70 to give serious and extended pause before unthinkingly consenting to a routine PSA test. So, what should you consider doing instead? If you are experiencing genuine urinary symptoms, such as hesitant flow, changes in stream, increased frequency, or waking multiple times at night to urinate, it is absolutely imperative to discuss these concerns with your doctor. These symptoms are clinically significant and warrant thorough investigation. Similarly, if you possess a strong, documented family history of aggressive prostate cancer, this vital information fundamentally alters the risk-benefit equation, and a more proactive discussion about screening may be appropriate. However, if you are over 70, entirely asymptomatic, and fall into an average risk category, the pivotal conversation with your doctor should not be a simple, "Do we screen?" Instead, it should evolve into a much more profound inquiry. What, realistically, would we actually do if we were to find something? And critically, is that potential treatment pathway demonstrably better for my overall life and well-being than a strategy of careful, active surveillance or watchful waiting? That singular, thoughtful question alone, when posed directly and thoughtfully, very often transforms the entire dynamic of the medical discussion. Checkup number 4, routine bone density DEXA screening paired with automatic long-term medication. Before anyone might prematurely conclude that this discussion advocates against addressing bone health, let me reiterate with absolute clarity. Osteoporosis is a genuine and serious medical condition, and the devastating impact of falls in older adults cannot be overstated. I wish to be exceptionally precise in this section, as there exists a crucial distinction between questioning the utility of a particular diagnostic test and questioning the often automatic and immediate pipeline of long-term medication that frequently follows a low bone density result. A DEXA, dual energy X-ray absorptiometry scan, is a valuable diagnostic tool designed to measure bone mineral density. If the results of a DEXA scan indicate low bone density, many medical practitioners, adhering to established protocols, move almost immediately to prescribing a class of medications known as bisphosphonates. These include commonly recognized brand names such as Fosamax, Boniva, and Actonel, names that have likely permeated your awareness through widespread pharmaceutical advertisements. The underlying message propagated by these ads, and implicitly by many doctors, is straightforward. Low bone density automatically equates to the need for medication, and medication in turn equates to assured protection against fractures. However, this pervasive message critically omits several vital pieces of information, overlooked aspects that are essential for truly informed decision-making. Long-term use of bisphosphonate medications, particularly when extended beyond 5 years, has been scientifically linked to a rare but exceptionally serious and paradoxical condition, atypical femoral fractures. These are stress fractures that occur in the thigh bone, precisely the bone you were attempting to protect and strengthen through medication. These atypical fractures can be excruciatingly severe, often necessitating complex surgical intervention, and in many unfortunate instances, they can inflict far more disability and impairment than the very fall or fracture they were originally intended to prevent. Furthermore, there is another concerning condition associated with bisphosphonate use, known as osteonecrosis of the jaw, a painful, debilitating deterioration of the jawbone that heals notoriously slowly and can be triggered by the very medication meant to bolster your skeletal health. Meanwhile, and this is the profoundly important part that should be an integral component of every single conversation regarding bone health, the single most effective, demonstrably impactful intervention for significantly reducing the risk of fractures in adults over the age of 65 is not, in fact, a medication. It is a comprehensive, multifaceted program focused on fall prevention. This includes structured balance training, with studies on practices like Tai Chi specifically demonstrating its capacity to reduce fall risk by nearly 50%. Other crucial interventions involve a meticulous review and removal of potential trip hazards within the home environment, the strategic installation of grab bars in bathrooms and other high-risk areas, a comprehensive review of all current medications to identify any that may cause dizziness or impair balance as a side effect, and annual vision checks to ensure optimal eyesight. These practical, non-pharmacological interventions are proven to reduce your actual, real-world fracture risk far more meaningfully and effectively than most pharmaceutical pills, and critically, they come with the unparalleled advantage of having zero adverse side effects. Consider Gloria, a 72-year-old former elementary school teacher from Phoenix, Arizona. Following her routine annual physical, she underwent a DEXA scan. Her doctor subsequently informed her that her bone density was below the normal range for her age, immediately prescribing a bisphosphonate medication and instructing her to take it indefinitely. 3 years into her medication regimen, Gloria sought my consultation after developing a persistent, aching pain in her thigh. Investigations revealed that she was suffering from an early atypical stress fracture, precisely the kind linked to long-term bisphosphonate use. The bitter irony was stark. Gloria had never experienced a fall, nor did she have any prior history of fractures. She had been diligently taking medication to prevent a fracture, and that very medication was, in fact, the underlying cause of her bone's pathological reaction. So, what are the essential questions to pose before automatically committing to long-term medication? You should ask, based on my complete medical profile, not solely on this scan result, what is my actual individualized fracture risk? And, crucially, can we thoroughly compare the potential benefits and risks I might derive from this medication versus the comprehensive advantages of a structured, personalized fall prevention program? This question is neither difficult nor confrontational. Any genuinely patient-centered physician should wholeheartedly welcome such an inquiry, recognizing its importance in shared decision-making. Checkup number 3, routine cardiac stress testing without symptoms. This is the checkup that most consistently elicits surprise and often disbelief from individuals, primarily because, on the surface, it sounds like an exceedingly responsible and proactive measure for health. Your doctor might suggest, "You're 68 years old now. Let's just make absolutely sure your heart is functioning optimally." This typically involves either exercising on a treadmill to elevate your heart rate, or, for those unable to exert themselves, administering a medication that temporarily induces a controlled stress on your heart, all while monitoring its physiological responses. What, logically, could possibly be amiss with such a seemingly prudent approach? Herein lies the critical problem, one that is almost never openly discussed or adequately explained within the confines of a typical appointment room. Cardiac stress tests, when performed on individuals who are entirely asymptomatic, meaning they experience no chest pain, no unexplained shortness of breath during exertion, and no activity-triggered dizziness, are associated with alarmingly high rates of false positives. In certain demographic populations, these false positive rates can soar to as high as 40%. This statistic means that in nearly half of all cases where a stress test flags an abnormality in asymptomatic individuals, their heart is, in fact, perfectly healthy and functioning normally. However, the medical establishment cannot simply dismiss or quote-unquote shrug off an abnormal result, even if it is a false alarm. That positive flag, that false alarm, inexorably propels you into the subsequent, significantly more invasive phase of diagnostic investigation, a cardiac catheterization. A cardiac catheterization is a serious invasive procedure. It involves threading a long, thin, flexible tube or catheter through your blood vessels, typically accessed via an artery in your wrist or groin, and carefully guiding it directly into the chambers of your heart. While generally safe, this procedure carries a spectrum of inherent risks, including potential bleeding at the access site, damage to the blood vessels, the induction of cardiac arrhythmias, irregular heartbeats, and in rare but documented instances, the catheterization itself can inadvertently trigger the very cardiac event, such as a heart attack, that the initial screening was ostensibly performed to prevent. Furthermore, if the catheterization identifies a partial blockage within a coronary artery, a finding that is exceedingly common in adults over the age of 65, including many who will continue to live for decades more without ever experiencing a single cardiac event, you may then be recommended for and receive a stent. A stent is a small mesh tube inserted into the artery to keep it open. Now, this is the pivotal piece of information I want you to truly absorb and understand. Multiple major clinical trials, including the landmark ischemia trial, which stands as one of the largest and most definitive studies of its kind, have unequivocally demonstrated that stenting in patients diagnosed with stable coronary artery disease, that is, blockages that are not acutely causing symptoms, did not statistically reduce the incidence of future heart attacks or extend life expectancy when compared to a comprehensive regimen of optimal medical therapy and intensive lifestyle management alone. To put it plainly, in these stable patients, the surgical implantation of a stent did not outperform the combined efficacy of a consistent 30-minute daily walk and the appropriate targeted medication. Yet the stent procedure inherently carried all the procedural risks of catheterization, and its placement often necessitated years of mandatory, costly, and potentially complication-inducing blood thinner medications. Therefore, the complete cascade effect for routine cardiac stress testing in asymptomatic individuals typically unfolds as follows. An individual feels perfectly fine. A routine stress test is performed. It yields a false positive result. This leads to an invasive cardiac catheterization. A stent is subsequently placed. The patient is then placed on long-term blood thinners, and they face ongoing medical monitoring. Crucially, at the end of this entire invasive sequence, there is often no statistically measurable improvement in long-term cardiac outcomes compared to a non-invasive, medically managed approach. That is the complete, unvarnished picture. And this entire, potentially hazardous journey was initiated by a simple, seemingly benign statement: let's just check. If you are finding this information valuable and pertinent to your understanding, please consider typing the number 3 in the comments section. It's a simple way to let me know you are following along, and your engagement genuinely assists this channel in reaching a wider audience who urgently need this critical information. So, what should you do instead if you are not experiencing any chest pain, no unexplained shortness of breath, and no dizziness specifically triggered by physical activity? In such circumstances, the conversation with your physician should not revolve around the necessity or advisability of cardiac stress testing. Instead, the focus should be entirely on optimizing your actual, well-established cardiovascular risk factors. This involves diligent management of blood pressure, proactive control of cholesterol levels, vigilant monitoring and regulation of blood sugar, maintaining consistent physical activity, and ensuring adequate restorative sleep. These are the domains where the most substantial and meaningful cardiac health gains truly reside after the age of 65, and none of these critical interventions require an invasive catheterization to access or implement. Checkup number 2, routine carotid artery ultrasound in asymptomatic patients. This particular checkup is another one that receives astonishingly little discussion in the broader public and medical discourse. Yet, based on the compelling evidence from robust data, this silence represents one of the most significant and potentially consequential oversights in routine senior care practices today. A carotid artery ultrasound is a diagnostic imaging test specifically designed to visualize and assess the large blood vessels located in your neck, the carotid arteries, which are responsible for delivering vital oxygenated blood directly to your brain. The underlying rationale for routine screening sounds inherently logical. Identify any significant blockages within these arteries before they manifest as a debilitating stroke. Then surgically clear out the blockage, and the problem, ostensibly, is solved. However, the reality of this approach is far more intricate, fraught with complexity, and for individuals who are entirely asymptomatic, it is often considerably more dangerous than it superficially appears. Here is the undeniable fact that fundamentally alters the entire equation. The surgical procedure employed to treat a significant carotid blockage, known as a carotid endarterectomy, a procedure to remove plaque from the carotid artery, inherently carries a non-trivial risk, approximately 2 to 3%, of actually causing a stroke during or immediately following the surgery itself. In older adults who often present with multiple other coexisting health conditions and comorbidities, that percentage risk is demonstrably even higher. The United States Preventive Services Task Force, USPSTF, which is widely recognized as the gold standard evidence-based body responsible for establishing national screening guidelines in this country, explicitly and unequivocally recommends against routine carotid artery ultrasound screening for adults who are asymptomatic. Their exhaustive analysis and conclusion are direct and unambiguous. For individuals who exhibit no symptoms, the inherent risks associated with the surgical intervention to clear a detected blockage unequivocally outweigh any likely potential benefit derived from the initial screening. Let's delve into why this is the case. A substantial proportion of adults over the age of 65 naturally develop some degree of narrowing or plaque buildup within their carotid arteries. This arterial narrowing has often been present for many years, remaining stable, entirely silent, and crucially, not causing any medical problems or symptoms whatsoever. When you initiate routine screening for such conditions, these often clinically insignificant narrowings are inevitably discovered. Following this discovery, a well-meaning vascular surgeon, acting in accordance with standard medical practice, will frequently recommend surgical intervention to quote-unquote fix the perceived problem. However, the very act of performing surgery to clear a blockage that was never causing symptoms carries a significant risk. A small piece of plaque can become dislodged during the procedure. This dislodged fragment then travels directly upward into the brain, where it can cause an ischemic stroke. In this deeply ironic scenario, the intended intervention, designed to prevent a stroke, becomes the direct cause of the exact outcome it was meant to avert. So, what should be your course of action instead? If you are genuinely experiencing no neurological symptoms, such as sudden unexplained changes in vision, a fleeting episode of facial drooping, sudden weakness or numbness in an arm or leg, or brief transient episodes of confusion or slurred speech, then routine carotid screening is, generally speaking, not recommended and should not be where your focus and energy are directed. Instead, your efforts should be channeled towards diligently managing the actual, modifiable drivers of stroke risk. The single biggest and most impactful of these is blood pressure. Its rigorous control is paramount. Other critical factors include the careful management of blood sugar levels, addressing atrial fibrillation if that condition applies to you, and consistently maintaining an active lifestyle. However, if you do experience any of the aforementioned neurological symptoms, even if they are brief, transient, and subsequently resolve, that entirely changes the equation. In such instances, it is imperative to seek immediate medical evaluation without delay. This is no longer merely routine screening. This is your body sending a clear and urgent signal that absolutely warrants an immediate and responsive medical assessment. Checkup number 1, routine colonoscopy after age 75 in low-risk asymptomatic adults. This particular checkup, the final item on our list, is arguably the most surprising and least discussed challenge to established medical norms. It is the one that most people have never heard questioned, primarily because colonoscopies have been so thoroughly, broadly, and consistently endorsed as a vital screening tool for such an extended period that raising critical questions about their utility in a specific context can feel almost counterintuitive, even heretical. However, the wealth of data, specifically pertaining to adults over the age of 75, particularly those who are entirely asymptomatic, possess a history of previous clean colonoscopies, meaning no polyps or concerning findings, and have no family history of colorectal cancer, narrates a story distinctly different from the generalized narrative most people typically encounter. The United States Preventive Services Task Force, USPSTF, in its meticulous, evidence-based analysis, explicitly recommends against routine colonoscopy screening for average-risk adults who have surpassed the age of 75. Their reasoning for this recommendation is far from vague or ambiguous. It is clearly articulated and based on a crucial turning point. For this demographic, the inherent risks associated with the procedure undeniably begin to outweigh the potential rewards. And these risks, it is vital to understand, are not abstract. They are very real, becoming concretely apparent when one fully grasps the spectrum of adverse events that can tragically unfold. One of the most serious complications is bowel perforation, which is a literal tear in the wall of the colon. This severe event occurs in approximately 1 out of every 500 colonoscopies. While in a younger, otherwise healthy adult, a bowel perforation might be a challenging but generally manageable surgical complication, in a 77-year-old individual, it can precipitate a genuine medical crisis. Such an event can necessitate emergency abdominal surgery, potentially leading to the creation of a colostomy, a surgical opening in the abdomen to divert waste, require an extended and debilitating hospitalization, and result in a recovery period that permanently alters their independence and profoundly diminishes their quality of life. This grim assessment doesn't even account for the arduous and unpleasant preparation itself. The large volume of liquid bowel preparation, designed to completely cleanse the colon before the procedure, can induce dangerous dehydration, severe electrolyte imbalances, and significant cardiac stress in older adults, whose physiological reserves are naturally diminished. Furthermore, the risk associated with sedation, an integral part of the colonoscopy procedure, progressively climbs with advancing age, adding another layer of potential complication. Returning to our longevity lens, it is also crucial to recognize that the types of colon cancers most likely to be detected in entirely asymptomatic adults over the age of 75 typically tend to grow at an exceedingly slow pace. They are often so indolent in their progression that in a substantial number of cases, they would never advance to cause significant problems or symptoms within that individual's remaining natural lifetime. Let me share the instructive story of Margaret. Margaret, at 78 years old, was a retired school teacher from rural Ohio, a woman of impeccable health and vitality. She had undergone 2 prior colonoscopies in her 50s and 60s, both of which were completely clean, revealing no polyps or any other concerning findings. She had no family history of colorectal cancer and experienced no symptoms of any kind. During a routine visit, her new primary care doctor reviewed her chart and informed her that she was due for another colonoscopy. Margaret, naturally, asked a few questions about the necessity, but she was reassured that it was a routine preventative measure. Trusting her doctor, she proceeded to schedule the procedure. The prescribed bowel preparation liquid hit her system with severe intensity. By the following morning, she was profoundly confused, physically weak, and barely able to stand independently. Her worried daughter, witnessing her mother's rapid decline, immediately rushed her to the emergency room, preventing her from ever reaching the scheduled colonoscopy appointment. At the ER, doctors discovered her electrolytes were critically low and her heart was under significant strain due to the severe dehydration. Margaret spent 5 harrowing days in the hospital, never actually undergoing the colonoscopy. The stark findings from those 5 days were profoundly ironic. Her heart and kidneys had been severely stressed, not by any underlying disease, but by a preparation for a procedure meant to screen for something she almost certainly did not have, and even if she did, would most likely have outlived without consequence. When Margaret called me after her discharge, her words echoed the now familiar sentiment. I felt better when I was overdue for that test than I did after trying to take it. So what should be done instead? Engage in an informed discussion with your doctor about the availability of non-invasive stool-based testing options, such as the Cologuard test or an annual fecal immunochemical test, FIT. These screening methods are designed to flag genuine warning signs of colorectal issues without imposing any of the significant procedural risks associated with a colonoscopy. Importantly, if you do experience any concerning symptoms, such as visible blood in your stool, unexplained and persistent changes in your bowel habits, or chronic abdominal pain, these signs absolutely warrant immediate and thorough medical evaluation, regardless of your age. These are critical signals from your body that require urgent attention, not routine screening. Now let's turn to the practical and actionable piece I promised you. Every single time a physician recommends a screening test, especially if you are over the age of 65 and currently feeling well and symptom-free, I want you to be fully equipped with 5 specific, powerful questions. I strongly advise you to write them down, store them in your phone's Notes app, and bring them with you to every single medical appointment. These questions are designed to empower you and ensure genuinely informed decision-making. Question 1. What is the false positive rate of this specific test in people my age and with my general health profile? Understanding this statistic is absolutely crucial because it directly tells you how likely it is that the test will yield an abnormal result, which could then propel you down an entirely unnecessary and potentially harmful path of further follow-up procedures, even when in reality, there is absolutely nothing clinically wrong with you. Question 2. If this test does find something, what are the realistic treatment options available for someone of my specific age and current health status? Do not allow the conversation to terminate simply with the statement, "We found something." You must actively push the dialogue further to encompass the essential "and then what?" This requires your doctor to be transparent about the actual interventions that would be considered. Question 3. What is the procedural risk of the treatment that we would most likely pursue if this test yields a positive result? Every single medical procedure, no matter how routine it may seem, carries its own distinct risk profile, encompassing potential complications, side effects, and recovery challenges. You unequivocally deserve to be fully aware of these specific risks before you consent to any procedure, not belatedly discover them after the fact. Question 4. What happens if we choose to monitor this finding instead of immediately treating it? For a considerable number of conditions that are frequently discovered in older adults, a strategy of watchful waiting or active surveillance is not only a legitimate medical option, but is very often the superior and less harmful approach. This is not about giving up or neglecting your health. It is about making the correct, age-appropriate mathematical assessment of risks and benefits. Question 5. What is the most effective, non-invasive approach for managing or addressing this condition? As we have thoroughly explored today in the contexts of bone health, heart health, and stroke prevention, a combination of targeted lifestyle modifications and appropriate medications frequently outperforms invasive procedural interventions, all while carrying a mere fraction of the associated risks and potential complications. Any physician who is genuinely dedicated to your best interests and truly quote-unquote in your corner will wholeheartedly welcome these thoughtful, probing questions. They will not, under any circumstances, make you feel like you are being difficult or challenging for asking them. Conversely, if a doctor dismisses these questions out of hand or makes you feel as though you are being a quote-unquote problem patient for raising such fundamental inquiries, that response itself provides incredibly important information. It serves as a vital signal about whether that particular doctor is truly the right fit for your healthcare needs and aligns with your philosophy of informed patient autonomy. Here is a practical exercise I want you to try, starting today. Before your very next medical appointment, whether it is scheduled for next week or 3 months from now, take a moment to write down those 5 crucial questions on a small note card or input them into the Notes application on your smartphone, ideally within this very hour. Bring that card or your phone into the appointment with you. You may not find it necessary to use all 5 questions. Perhaps you will only need to pose 1 or 2. However, the mere act of having them ready and available subtly yet profoundly changes how you present yourself and engage in that examination room. And, critically, how you present yourself and participate in that room fundamentally changes the ultimate trajectory of your health outcomes. Commit to doing this for the next 30 days. For just one appointment, apply those 5 questions. I can almost guarantee what you will experience. By the end of those 30 days, you will feel a transformative shift, emerging as a distinctly different kind of patient. Not a difficult one, but a deeply protected and empowered one. You will possess a clear understanding of the true purpose of the test, the genuine implications of any follow-up recommendations, and most importantly, you will know precisely which critical questions to ask before the potentially detrimental cascade effect ever has a chance to begin. There is undoubtedly someone significant in your life, a beloved spouse, a sibling, an adult child who responsibly manages the healthcare of their own aging parents, who urgently needs to hear and internalize the critical information we have discussed today, ideally before their next annual physical examination. You do not need to undertake the daunting task of explaining all of this nuanced information to them yourself. You can simply share this video with them, allowing these vital insights to reach them directly. If this extensive conversation has profoundly altered your perspective on what constitutes truly optimal routine care after the age of 65, I sincerely encourage you to subscribe to this channel. Next week, I will be delving into another critically important topic that connects directly and seamlessly to everything we have explored today: the specific categories of medications that are routinely prescribed to adults over 65, but which possess a completely different and often significantly altered risk profile at that age compared to their use in individuals at 50. I will also provide essential questions to ask your pharmacist before you ever refill these particular prescriptions. If you currently find yourself regularly taking more than 2 daily medications, that upcoming video was specifically crafted with your well-being in mind. Please do leave a comment below. Have you ever personally experienced a routine medical test that unexpectedly led you down a path you neither anticipated nor desired? Your shared experience